Ready. So hi everyone, I'm Jeein Yoon again, one of the child and adolescent psychiatrists working at Oakland Children's, and I'm here to do a short lecture on sleep for the first 20 to 30 minutes, and we'll do a case discussion following. So really, I have no financial disclosures, nor does anyone on the team have any disclosure. But the objectives is really to explain how to conceptualize sleep difficulties in children and describe how to behaviorally approach these treatments, and also explain the guidelines for medication use as an adjunct in treatment for children with sleep difficulties. So pediatric insomnia really by definition is similar to adult insomnia. It's repeated difficulties in falling asleep, staying asleep, or just having poor quality in general. But there is a clause that there has to be sufficient opportunity for sleep, and the sleep duration for each children is defined differently depending on the developmental age. A lot of times we rely on the parents' report or the caregiver's report. So we do consider or factor in the history of how much it is impairing the family, resulting from the child not being able to sleep well. Next. So about 20 to 30% of preschool age and younger children do report sleep difficulties. Overall, in the big picture, it's reported in literature that about 10% of children under 18 have sleep difficulties, and 10% to up to 30%, depending on the study, show that there is actual insomnia. But what we often as providers, but also as parents and caregivers, neglect to grasp is that sleep is actually a developmental process. So in the first 5 years, really what's happening is we're consolidating the sleep and also getting a hold of the regulation of overnight time. So just educating the families about that. It's not something that comes naturally for everyone. It is a developmental process, and it might change from year to year, and depending on the developmental delay of the child or any other medical factors underlying, this can be different and it can be challenging. So on top of that, you also want to consider any environmental or cultural aspects that play into the picture. So I kind of inserted a little chart on the right side of the bottom. Everyone probably familiar in primary care with this. A couple years back, AAP and the American Academy of Sleep Medicine put out guidelines for how many hours of sleep is developmentally appropriate. The key point here that I like to really highlight is 10 hours at age 10 is kind of my standard guideline. For elementary school kids from 6 to 12, it's usually 9 to 12 hours. And it doesn't really vary much for teenagers as well. You need about 8 to 10 hours as teens, and none of our teens are really getting this. If you look into the studies, really, for middle school kids, only 4 out of 10 kids are getting adequate sleep. And for high school kids, only 3 out of 10 kids are getting adequate sleep. So it just gives you a good guideline of how sleep deprived our kids are. On top of that, you have to factor in that with puberty starting and the hormonal shifts, there becomes a circadian rhythm shift of about a 2-hour sleep phase delay for the teenagers, which doesn't really help the situation. And on top of that, they have a lot of academic demands, extracurriculars, and peer pressure. They're playing games or on the phone at night. So that's not really helping the situation as well. Next. So the American Academy of Sleep Medicine put out a consensus statement. Found many evidence-based studies that poor sleep results in attention problems, behavioral problems, and learning problems, which we all are aware of. And it does have a positive correlation in terms of its effect on depression and actually increased suicidal ideation and attempts. So that's something to be noted. And other medical physical factors of increased risk of hypertension and diabetes or obesity in the long run. Next. So I just wanted to briefly introduce like a 3P model of insomnia. It's just a model that we use to conceptualize and formulating what is actually going on in this child's life. So Spielman came up with a 3P model. The 3P stand for like predisposing factors, precipitating factors, and perpetuating factors. In psychiatry, we usually use a 4P model to come up with an assessment and a formulation for what is actually contributing to the patient's presentation. So it's very easy in terms of looking into the predisposing factors. Are there any genetic factors? Does this have a genetic syndrome? Or are there any biological factors that are contributing with any medical issues that are underlying? Sometimes you have to consider into factors like personality and temperament as well, and those would all fall into the predisposing factor category. For precipitating factors, you want to assess for, are there any triggers to these sleep issues? Like, were they scared about something? Was there a move in the family that is an environmental change? Was the child sick, or are they in pain? Was there a loss, or are there any other acute stressors? Those would all fall into a precipitating factor category. And then you want to like assess for, are there any perpetuating factors that are letting this continue, like behavioral wise? Like, is it coming from the child, or is it a factor with parenting and you're reinforcing these unwanted patterns? Also, you want to assess for, are there any medications like stimulants that are like counteracting with sleep? Are they taking unnecessary prolonged naps in the afternoon to the evening? So on the right side, you can see that they kind of broke it down on the x-axis to how long the insomnia has been ongoing for, and the y-axis looks at the severity of sleep difficulties. As you can see, if it's more of an acute sleep difficulty, you have more predisposing and precipitating factors. But as the sleep difficulties have been ongoing for more than 3 to 6 months and years, you kind of consolidate more of the perpetuating behaviors. So the proportion of what is actually contributing to your sleep difficulties becomes flipped. So you'll have more perpetuating factors that are contributing to your difficulties. Next. So this is something I put together in the handout, and we'll be emailing it out at the end. There is a screener for sleep. It's called the BEARS for mnemonics. It stands for bedtime resistance, excessive daytime sleepiness, awakenings at night, regularity and patterns, and snoring. So it applies from age 2 to 18. You can give it out to the families if you would like, but it's really more meant to be a guideline for your clinical interview during your visits. But like with bedtime resistance, you want to know what the sleep arrangements are. Are they co-sleeping? Do they have bedtime routines? And if so, how long is it, and what consists of your routines? How do the parents respond if they get into bedtime struggles? For excessive daytime sleepiness, you want to ask if they are feeling tired. Are they falling asleep during the night? Is it impairing their function in school? How many cups of coffee or like tea are they drinking that contains caffeine? Chocolate milk also counts, so you want to be careful about asking about those details. Are there any stimulants or other medications that are really counteracting with their sleep schedule? Awakenings at night is something that you want to be very detailed about, like how often is it happening? What time are they waking up? Are they able to fall back asleep? If they aren't, how long does it take before they can fall asleep? Are they doing any behaviors? Are they getting out of bed and eating or watching TV or the tablet? Any other parasomnias you want to screen for, as well as seizures and enuresis. For regularity and patterns, it's what we think of as diary. So like the regularity, is it pretty consistent? Is it here and there? What time are they falling asleep? How long do they take to actually fall asleep? And snoring, any sleep related breathing problems that you want to screen for here. Next. Oops. So when to refer for a sleep study, I know primary care does this very often. Of course, you want to rule out any OSA if you have symptoms concerning for it with apneic episodes or any daytime symptoms such as fatigue or falling asleep. The rest, like the sleep-related movement disorders, definitely warrant a sleep study. So restless leg syndromes or periodic limb movement disorders. And one other thing that you want to screen for is narcolepsy. More often than not, I don't think I've ever kept it on my radar, but it is reported that a lot of kids from like age 6 to teenage years, that's when the narcolepsy does come about, but it doesn't get picked up until much later. So you want to do a thorough history about whether they're having any drop attacks or like excessive daytime sleepiness that might warrant like MSLT. So next. So the most common category of sleep difficulties that children will fall into would be the behavioral insomnia of childhood, which we call BIC in short. So there are two or three types actually. There's a sleep onset type, a limit setting type, and a combined type where they have both of the sleep onset and limit setting difficulties. So the sleep onset type is what we know more as like the child needs a very specific conditioning to be able to fall asleep. You've probably heard about like my child needs to be rocked to bed. They won't fall asleep on their back. We have to hold them and then lay them back down, or parents are driving the kid around in a car seat for an hour every single night, and they have difficulty falling asleep. Sometimes it's because of the temperament of the child. Sometimes it's a combination of parenting style or the parent being very overly anxious, or just like given the sleep environment that they don't have a separate bedroom and it's just been set up that way. Sometimes it's cultural as well. With the limit setting type, it's more often the behavioral tantrums that happen are around sleep routines, or if it's not an overt tantrum with yelling and screaming and refusing, they might look for curtain calls, like excuses. Can I have one more cup of like milk or something? And they keep on crawling out of bed. So the child is actually delaying the onset with refusal to sleep. Next. So I'm going to go through like an example of behavioral structuring. I know a lot of pediatricians do counsel, but I wanted to just give an example of a step-by-step. So first thing is that you want to set up a bedtime that is going to work for the child, appropriate to the child's developmental age. And firm bedtime limits, you want to set up a bedtime routine that's no more than 2 to 3 activities during that short 20 to 30 minute period. You want to explain the rules up front with the child, but be very concise. There's no negotiating or going back and forth. And the sleep schedule really shouldn't vary more than an hour from school days to non-school days. So 7 days out of the week, it should really fall within a 60-minute window. Setting the bedtime goes by the developmental age, but first thing, most of these kids will come with having difficulty falling asleep, and we're not going to go from ask a child who's falling asleep at 1 a.m. to go to bed at 9. That's never going to work. So we use something called bedtime fading, and you're going to set a temporary bedtime with the family, which is going to be the time that the child falls asleep right now. So around 1 o'clock, you set like something between 12:45 to 1 initially. And the goal is to have the child fall asleep within 15 minutes of that temporary bedtime. Once you achieve that for about 3 days to a week, you will move that bedtime from 12:45 to 12:30 by 15 minutes earlier. And the goal is really we're resetting the time clock and kind of reconditioning that the child is going to fall asleep when they're in bed. So you go from 12:45, 12:30, 12:15, 12, all the way to like, let's say your targeted bedtime of like 9. So it's going to be a process. It's going to take time, and the parents have to be consistent with this. The routines really should be very short. It should be calm, enjoyable activities like bath time, reading with parents, bedtime stories, and then like just going to bed in a calm, cool environment. Usually we even say that the bedroom should be a little bit cool, less than 75 degrees Fahrenheit, and dark. If the child's scared, you can do a little like dim light or with in the bedroom, but nothing too bright, no electronics, of course. And you can use visual charts for kids who are a little bit younger so they can be cued that these are the routines they need to do. Next. Next, you're gonna have them put the child in bed, but leave the room before they're actually out. The key to this is we don't want to associate the parents being there being a condition they have to hit before they are able to soothe themselves to fall asleep. Now, if the child cries and yells, we have two methods, right? A modified, like go cold turkey versus a gradual extinction. I can't say one is better over the other, and I really would suggest like playing it by ear with the family and the comfort level of the parents. It is, I think, a very challenging task, as it's not going to go away in a couple days. Normally, we say at least 3 weeks or longer for a habit to break. So with the child, just gently remind them it's bedtime, and then mom's going to leave the bedroom, but periodically check in if the child's anxious or they're calling out, and just reassure them that they're there, but you're not engaging in long conversations or negotiations. And don't soothe them. We're just really trying to teach the child to self-soothe. So you're leaving, coming back in. And with gradual extinctions, if you want to choose that method, you can kind of start beside the bed on the floor and then kind of gradually move towards the door and outside the door in incremental time. If the child tries to leave the room and follow you, you just calmly, firmly remind them it's bedtime. They need to do this on their own and return them. But of course, we don't want to cause any big traumatic experiences, so don't lock them or don't scold them. The key is to remain calm and firm and consistent. Next. Most importantly, you want to put in some positive reinforcement strategies with rewarding systems. So focus on just the positive behaviors. There's no need to rehash what they did wrong, how much of a pain they were last night. You can use sticker charts, praises, favorite breakfast items to reward them in short term. Short-term rewards are really great. And the key is to be consistent and be calm, but warn the parents of the extinction burst that things could be worse before they get better. So sleep difficulties in special pediatric populations, and we get a lot of these neurodevelopmental disorders like kids with autism spectrum, developmental delays, and any genetic syndromes, not only because of that, but it's also comorbid with behavioral insomnia of childhood, poor limit setting with parents, and a lot of caregiver stress. And they come to you with, I give up, I really need help, and we feel their pain. But before you give out any medication or jump to any conclusions, I think we have to be very mindful of like ruling out any underlying medical problems as listed, any chronic diseases like asthma or like eczema, anything, pain syndromes, and comorbid psychiatric disorders is something you want to screen for as well. Next. So ASD and sleep. More than 50% of the ASD populations is reported to have sleep difficulties. I think some studies report up to like 75 to 80% even, and half of those kids have difficulty falling asleep, but another half of those have comorbid like difficulties with maintaining sleep. There's a theory behind that circadian rhythm dysfunction underlies, or maybe they don't produce enough melatonin. So the American Academy of Neurology came up with practice guidelines last year saying that you need to rule out any underlying medical causes or medication causes that might contributing to the insomnia. But first line is always behavioral strategies like we discussed, but low dose melatonin is really helpful as well. Next. So the study that supports this found that melatonin plus CBT, or even melatonin alone, if you don't have access to CBT, is helpful for all realms of the bedtime resistance, like sleep onset, sleep maintenance, and daytime behaviors. Next. So CBT for insomnia, in short, we call the CBTI. I just wanted to like kind of introduce the concept. We have very limited access to providers who know how to do CBTI. But the point of me sharing this slide with you is because a lot of what is incorporated into CBTI, we're already doing as primary care providers. The sleep hygiene education piece, the stimulus control is really just uncoupling the bed from other activities. Bed equals sleep. You don't do anything else there. And if you're lying in bed for longer than 15 minutes, you get out and do something low stimulating. The sleep restriction piece is what I just discussed with the bedtime fading, with moving up the temporary bedtime to your actual desired bedtime by 15 minutes every three plus days once you achieve the sleep efficacy. And then relaxation techniques are usually just like breathing exercises, meditation, guided imagery that you can probably discuss with families. Now, the difficult piece that you're probably not familiar with is the cognitive therapy piece. And this applies more to more to like older people than like younger kids with if they have any fears about not being able to sleep. I'm gonna like mess up my exam tomorrow. If I don't sleep enough, this isn't gonna work out, or they're ruminating at bedtime. That's where the therapy really kicks in. But this is all incorporated into CBTI. Next. So for pediatric insomnia, there are no medications that are FDA approved, no medications. So meds are never the first treatment choice and should not be used alone. If you do have to use meds, it should be used only for short term, and that should be communicated with the families up front. And you want to screen for any illicit drug use or over-the-counter medication use as well. Next. So melatonin, I'm going to briefly discuss because I think a lot of people are using it over the counter, which is great. It has two properties. One is a phase shifting chronobiologic property, and the second one is sleep promoting. It works best if you give it about 30 minutes to 60 minutes before bedtime. And the dosage range is anywhere from like 1 milligram to 10 milligrams, especially in the special needs population. You can push it up to 10 and that's fine. For normally developing kids like sleep medicine, folks usually like to use 0 to 3 milligrams. Next. Okay, I think we're gonna stop here and move on to the case discussions, and I can fill in on the medication piece at that point if we need to.
Wonderful. Thank you so much, Jean, for this. And our case today, we're going to be moving to our case. And our case today actually casts